Ladies and gentlemen, we're going to start very shortly, if we may. My name is Jim Pollard. I'm a former board member of the club. Still doing a little bit of work from home. Thank you for coming today. I think this is... We've got our special guest, Dr. Cynthia, has been a regular at this club over the last probably 20 or more years. She's undoubtedly one of the most outstanding humanitarians Myanmar has produced, and a pillar of strength on the border. Today's event, I'll go through it with you shortly, what's going to go on. It's relatively straightforward. I think there have been this is the third report, I think, of this kind of survey. The first one drew a very significant response because I don't think people in 2008 realised how serious the health situation was in Burma. And that makes today's event quite significant as well, because it's the health situation is arguably even worse right now. Anyway, but the first thing I want to tell you about is upcoming events at the club. The one of greatest interest probably to people here is 1 week today, Fortify Rights, the human rights group run by Matthew Smith and his wife. They're going to launch a report on war crimes in Myanmar. So they'll probably need a wheelbarrow to carry that report in, but anyway, that's 10 o'clock, September 4, next Thursday. Right. And I might ask, Dr. Cynthia, is it okay for you and the others to come up now? Please, thank you. Just to give you a run through of what we've got, I hope everyone's got a copy of the two books, right? Oh, sorry, the magazine and the brochure. I'm going to just give you a brief introduction, and then Dr. Cynthia is going to give you some background and an introduction on the concept of what this survey is about. After that, they will present the key results. That will be Saw Natu. And then there will be recommendations on the key health related advocacy. And following that, there will be a question and answer period of 20-30 minutes, depending on whatever's required, and just a summing up. Just a bit of background information for you. Some of the teams involved in this survey, the title is Ethnic, Demographic and Health Survey 2024. Backpack Health Worker Team was one involved, along with the Burma Medical Association, the Civil Health Development Network, the Karen Department of Health and Welfare, Kachin Women's Association of Thailand, and the Mon National Health Committee. This is the most extensive assessment of health and well-being in ethnic and conflict areas since the coup. So that's 4.5 years. People were talking, over 3,000 households were approached, 15,000 people. They spoke over 10 different languages and were from several different faiths. So it's quite an exercise and quite an important one, probably, to help people in the areas close to the border who are struggling, being bombed, by planes paid for by Beijing, and all those sort of things. So, Dr. Cynthia, do you want to take it away?
Yes.
Okay. Thank you.
Thank you, Jim, for kind introduction, and thank you for all of you joining this events. For me, I will start with the organization or the network called like Health Information System Working Group. So Health Information System Working Group was formed in 2002 in order to standardize or collect the data in the Eastern Burma or ethnic region. So before that, there are several ethnic health organizations and community organizations working on the healthcare services do not have standardized information system. So since 2000, the data being collected from health services, as well as in 2002, the first report called like chronic emergency was launched. So it is revealed that the human rights violation impact on health and the serious of the impact of the health on the maternal child health or nutrition. And then we can also see that the forced displacement or forced labor and food destruction is ongoing in the ethnic region. So that made more people vulnerable crossing the border from Myanmar to Thailand, and the infectious disease like malaria and other preventable childhood disease, pneumonia, diarrhea, is the main cause of death, under 5 death. So since that time, the ethnic health organization strengthened the level of care and the system to enhance the capacity of the ethnic health organization. So the Health and Human Rights Report make sure that our health program or health services reach to more people, so equitable access to healthcare services as well as strengthening the local governance system is the key to protect and promote the vulnerable population. And another issue I would like to highlight is since that time, the level of coordination and the partnership among the ethnic health leaders and organizations being strengthened. And we also have, there are several other joint programs like Malaria Elimination Task Force or Health Information System Working Group. And at the same time, we also have the Health Policy Development Working Group. So these are the connection and the building for the future federal system has been moving from the ground, as well as building the trust. But since 2021 military coup, we can also see that the escalating of the human rights violation as well as the mass displacement across country, and the health facility and infrastructure being disrupted. But actually, this is the community resilient and the community responsive action is amazing, because the community continue provide essential services like maternal child care services and try to reach to the people, reaching to the more vulnerable people, as well as training for health care worker is continue, and joining together with the newly displaced health professional to improve access for life-saving emergency services like emergency obstetric or injury management. So the network and the connection among the ethnic organization and the health professional being expanding day to day. So I would like to highlight that the local health system being strengthened, and then there are a lot of restriction on the accessing the services for community, because they are in the middle between the central control, AC control and the Thailand. So This community between in the conflict zone are working very hard for innovative way to reach more population as well as to scaling up the existing health services. So this report also call action to continue support and strengthen the local organization and to make sure that the coordination among the different international NGOs and the neighboring country is very crucial for the continue develop our future for the federal government or federal union. Thank you.
Sorne too, would you like to take over from here? You're going to talk about the, is it the key results? Please, thank you.
Yeah, thank you for giving me a chance to talk about the survey finding. Also, thank you very much, Dr. Cynthia, for giving a brief opening remark. So, good morning, everyone. Actually, 10 years ago, I think more than 10 years ago, in the year 2014, we were here at that time with our third report, The Long Road to Recovery, 10 years ago. But now we are the last one. We do survey in the year 2024. Actually, it is our great honor to welcome to you all to the launch of the Ethnic, Demographic and Health Survey 2024 report. Actually, this report represents the most comprehensive population-based assessment conducted in conflict-affected areas since 2021 coup. This is the first time. It is not only shed a light on the current state of health, also their displacement, but also highlight the remarkable resilience of the community who continue to survive and adapt under extraordinary strain. Today's launch is not about only presenting the numbers and data, also about creating a space for us to reflect, learn, and work together to strengthen health systems for those who are most affected and most needed. So to begin, let me briefly share the contents of Burma. Of course, community today is face overlapping crises, comprised of armed conflict, state collapse, and humanitarian emergency. Is deepening vulnerability nationwide. Also, decades of marginalizations. The 2021 coup is also combined with the COVID-19 pandemic, accelerated the collapse of services, leaving local authorities, local actors as frontline providers of care. And yet, amid with the fragility, there is a resilient community-based ethnic health networks continue to sustain these critical services obtained against all odds. That is why today survey is so vital. It's provide evidence rooted in the realities of community on the ground. Actually, the EDHS 2024 is the first major post-coup survey. It's making a critical source of evidence in the current crisis in the content. It's cover areas including mobility, mortality, nutrition, migration, resilience, also providing comprehensive pictures of community well-being. The purpose of this survey is to generate reliable community-based data that can guide humanitarian response and policy making. Also the advocacy that ensure the interventions are grounded in the realities of ethnic conflict-affected population. These surveys were made possible through the network. We call it like a HISWG, Health Information System Working Group. It's 9 partner organizations, including ethnic health and community-based health organizations working in Siam, Karen, Mon, Karenni, and Kachin. It's focused on the communities, often excluded from the national data, ensuring that the voices of the marginalized population are heard, represented. This survey was conducted in ethnic and conflict-affected regions by focusing on border and hard-to-reach communities. It highlights unique challenges from health, education to displacement and resilience, amplify the voice of marginalized population, marginalized group. For the methodology, using the stratifying cluster sampling approach, the survey cover over 3,100 households and 15,100 individuals, making it one of the most extensive since the coup. Conducted in October to November 2024 under difficult conditions, survey was carried out in local languages, ensuring inclusivity and trust and accurate data. And also this gave us confidence that the findings reflect the true realities of these communities. Well, the analysis of these surveys use descriptive statistics, prioritizing and weighted results to provide timely insight, though this limits generalizability. Some areas were inaccessible, leading to underrepresentations. Also, displacement also made difficult to capture stable population data, and also the recall bias may affect the responses. Of course, despite this limitation, we find that the findings we made highly valuable for planning, reflect realities faced on the front line. Now that we have reviewed the methodology and its limitations, let me start talking about the findings of the survey. We have a community survey, household survey. The community surveys look at the governance, infrastructure, education, markets, and humanitarian assistance. Is showing how systems support resilience. At the same time, the household survey focus on demographic migration, health indicators is bringing the data closer to daily life. Together, these findings highlight both areas of strength and where urgent support is needed. Let me begin with a finding on the community resilience and governance, which show how local structure network continue to sustain essential services despite crisis conditions. Our survey cover 164 clusters made up of the 23 IDP camps and 141 villages. You see here from the data here, governance highly, mainly led by ethnic revolutionary organizations, 66.5, followed by local militias with 25%, and other people defending force, PDF 4.3%. This clearly confirms that local and ethnic authorities remain the backbones of the governance in these areas. Turning to infrastructure, we see a mixed picture. Infrastructure show serious gaps, while water access cover over 60%, only half have electricity and phones, and less than 40% have reliable transport connections. These gaps in energy, communication, mobility continue to sustain the community. Let us now look at the finding on education and markets, which show how conflict and displacement have disrupted both learning opportunity and access to livelihood, while also highlighting the ways to the way community adapt to sustain school and local economies. Primary school, primary education is accessible over 70% of community, but when it's come to secondary education, reach only 25 to 40%. Of course, markets are generally open, yet restricted by the insecurity and transport barriers. Still, communities continue to sustain both school and trade under challenging conditions, you can see here. Looking at the humanitarian assistance, the picture is deeply concerning. You see here, over 60% of community report no external aid, living in conflict-affected areas with major gaps in support. People depend on the local coping strategies, ethnic providers, despite their limited resources. They show how urgently humanitarian assistance is needed in that area. Let us talking about the talking about the household survey session by looking at where the service was conducted and who was represented. The surveys cover household mainly in the Karen over 41%, the Karenni over 23%, and Shan South about 11%. The largest ethnic groups represented were Karen, 39.5%, Kayan, which is one of the Karenni ethnic groups, 22.9%, the Mon, 15.6%. These ensure our data reflect the realities of major communities in conflict-affected areas. Turning now to the demographic and social profiles, we see several important features of the survey population. Households are on average 5 members and nearly half populations under 25. Education levels remain very low, with about 60% relying on agriculture for livelihood. So this shows that the communities are young, agrarian, facing challenges in education and income opportunities. Looking more closely at the literacy and education, the data confirm that formal education level remain low in the survey area. Almost 25% are illiterate, while most have only reached primary school, about 39%. For a few continue secondary or high levels, and showing how restricted education pathway remain in these communities. Now turning to the livelihood occupation, the data shows strong depend on agriculture. Nearly 60% of households depend on farming, with most other in unskilled wage labor or reporting no work. Very few are salary job or business, showing narrow and fragile livelihoods remain. This reliance on agriculture pulls many families forward towards the migration when crisis hits, quick crisis come. Well, looking at the migration trend, we see a strong concentration in certain areas. Migration is highly concentrated in the Karen and Karenni, about 80%, with 2/3 of migrants under 25. Girls often migrate for education and domestic work, while boys migrate for labor and income. This highlights how migration is a key survival strategy for them, but one that carries risk, especially for the youth. Now, looking at the wealth distribution, the finding highlight a significant economic vulnerability. The bottom 40% of households are the most vulnerable with extreme poverty highest in Bago is about something about like 45%, and widespread in Karen, Karenni, more necessary and Nibido. In contrast, Kachin comes show more middle-income household. This underscores the needs for the targeted support for the poorest regions. It's now turning to mortality rate. That way, the data highlight a stark, urgent reality. The crude mortality rate match the national average at 9 per 1,000. But the child mortality is far worse. Infant mortality rate is 62, almost above the national rate, while under 5 mortality rate is 85 compared to 49 nationally. You see that this number is like it signals the severe crisis in child health. Now we're looking at the maternal and reproductive health. The findings are also seem like a deeply concerning. The average first pregnancy is at 21.6 years, but one in 3 pregnancy ends in miscarriage. Only half of women start antenatal care early, and early 60% deliver at home, which is not good. Often without skilled support, this point to the urgent needs for early ENC, safer deliveries, and trained birth attendant. When we look at the family planning, the data show a major gap in reproductive health services. Only 42% of women use contraceptives, leaving the unmet needs of the 58%. It could be like a barrier, or could include awareness, access, cultural norms, creating a serious reproductive health gaps. Alongside maternal health issue, we also see a significant burdens of the non-communicable diseases. Here we can see like hypertension, smoking, alcohol use are major risk factors, especially for women, among women. Yet the care cascade show very big gaps with low treatment and poor adherence. This analyzes the urgent need for the integrated NCD program that combine prevention, treatment, and long-term support. The survey also revealed alarming pictures on mental health. Depressive symptoms affect 41% of people in survey area, nearly double the Myanmar average, and higher than the other conflict-affected countries like Syria and Ukraine. Of course, this is a major mental health crisis requiring integration into primary care and targeted support in high burden areas. Building on the discussion of health outcomes, let us now turn to disability, and areas often overlooked in conflict-affected settings. Actually, this is the first ever measurement of disability prevalence in ethnic conflict-affected areas. The disability prevalence is just 2.8%, far lower than the national, with their 12.8%. And also global average is 16%. However, these gaps likely due to stigma and underreporting and leaving people with disability in hiding and underserved population. Despite to the urgent needs of inclusive services, we normally before we never collect the prevalence of disability, but this time we include this as kind of the could be baseline data for the ethnic areas. Looking at malaria prevention, we see the clear gaps between ownerships and use. So while 87% household own bed nets, only 22 to 42 persons are protected by insecticide-treated nets. This gap shows that ownership does not really equal protection, and highlighting the need for better distribution and consistent use and a replacement strategy. Now, turning from health indicators to broader context, the survey also captured the devastating impact of the coup on the communities. Conflict, exposure, stress, and income loss have hit community very hard, with like 24% experience death or injury, while 75% live with insecurity-related stress, and 49% reported lost income. These shocks show how conflict erodes resilience and pointing to the need of a stronger recovery strategy in the area. It's on to the food security and nutrition. We see worrying levels of the child malnutrition. Here we can see the number, global acute malnutrition is 6.1% overall. Is rising to 7.6 in Karen, and critical conditions like 16.3 in Nibira. This highlights the urgent needs for the target nutrition intervention in hotspot areas. Looking at the women of the reproductive age, the data show a serious public health concern. Overall, 30.1% are moderately minorities, rising to 16.6% in current state. Of course, it's alarming, 57% in Nibira. This show that nutrition support for women of reproductive age are needed. Here almost comes to close. In the conclusions, the survey show gaps in health services, high nutrition vulnerabilities, regional disparities, and yet community actors, the local authorities continue to sustain services under extreme pressure. This is a call for the conflict-sensitive inclusive policy, and using this evidence to guide both immediate intervention and long-term planning. Based on this finding, our recommendations are clear. We want to urge local actors should partner with ethnic health organizations, invest in infrastructure, use local data. Diplomats should protect community system, and of course donors must fund underserved regions with the multiple year support, and neighboring countries should strengthen border health collaboration. At the same time, foreign investors must adopt conflict-sensitive practice to ensure health and resilience are strengthening. Together, this action will help us to build inclusive, community-driven health systems that are equitable, resilient, and capable of meeting the urgent needs of the people in Burma, conflict-affected areas. Finally, we would like to thank all of our partners, donors, community workers who made this survey possible. Above all, we recognize the strength and resilience of the community that's at the heart of this work. So together we can turn this evidence into the real change and better health for all. Thank you all here.
April, you want to say anything now?
No.
Okay. Cynthia, can I just start with a small question to you? Of those findings, what worries you the most? Is malnutrition amongst young kids one of the biggest concerns?
Actually, since the coup, we see the ongoing displacement. Many of those are young people, children as well. So in this survey, it also showed that many young people, they migrate to neighboring countries. So to respond to the humanitarian needs, we need more protection for women, children, as well as the humanitarian workers, because the humanitarian workers are also under threats, and the health facility are ongoing attack, and people have to build their shelter underground like a bunker. So the children who are study the learning age, they suffer from mental health, and women also access to emergency obstetric or life-saving emergency stay very low. So our worry is this very fragile and disrupted environment. So the whole community suffer almost now more than 4 years.
Okay.
So we need more collective and urgent action to protect those vulnerable people and to enhance our capacity collectively.
Okay. That forced conscription began earlier this year, was it?
Post-conscription, I think in the 2024, early 2024.
Early last year, okay.
So, yeah.
So essentially a lot of those young men have come to Thailand and they're trying to find work. They're being absorbed into border communities or anywhere they can go in Thailand. It looks like this recent situation, the clash, the conflict that Thailand has seen down on the Cambodian border, it's estimated the amount of Cambodians who have left could be around 500,000. It's obviously a bad thing for bilateral ties there, which could take some time to repair, but it sounds like that's actually may help young Burmese men who are here find it easier to get work. It looks like the government here in Bangkok is stressed and needing migrant workers. Just yesterday they announced that people in the camps who for 41 years have never been able to work have now been given a green light to work. So that is a very positive thing, I would imagine, for people in the camps who, that is because Donald Trump cut USAID funding, which made up most of the money that was given to the border consortium that was providing food to the camps. So that's a positive development. And I would have thought that this crisis down on the Cambodian border may actually help young Burmese men who are coming here wanting to work. The government is probably going to be much more prepared to turn a blind eye of how they've got here and just get them into work. Any comment on that? Either of you? Sornatu? I mean, by the sounds of it, when your people were going out and getting the information from these clusters of individual, all in the eastern states, a lot of those communities are dominated by women, by the look of it, women and children. Yeah.
Yes, thank you for the question. It is really good that the Thailand has been approved that the refugees populations will have a right or chance to kind of officially work in Thailand. But over a decade, they have some rights, working outside of the camp in the past. For the young people from the Burma to officially cross and get an opportunity along the border, it is quite challenges at the moment, because you may see that the second relationship bridge of the Myanmar bridge has been now closed. It is also become one challenges for the young people, and also the current power holder is also very restricting or limited the travel of the movement of the people. So I think this will be very quite challenging for the people, to get opportunity, in the Thailand. Of course, people who used to stay in Thailand and don't want to go back to Burma, I think the Thai government have some plan for them to kind of work here in Thailand. Yes, thank you very much.
Okay. Ladies and gentlemen, if anyone wants to ask a question, there's a microphone just there. Just give us your name and tell us what group you're from. Anything at all, except a big argument on right and wrong, I suppose. But just in terms of those other findings, you've always had a serious malaria problem on the border. You've still got the SLOCO group doing work there. Has it disrupted their work in countering the spread of malaria badly? I imagine, frankly, it has, but are you getting more malaria arrivals at Maytao Clinic?
I would like to jump on response to the malaria cases. Actually, this service, we can kind of collect the information about banner usage just for prevention of the malaria. Actually, in the border area, especially particularly in the current states, the KNU administration areas, we have a kind of a consortium we call malaria elimination group, comprised of the SMRU, BMA, also KDHW. So that data cannot represent the whole, the entire areas of the administration areas. But of course, I can give you more information about the trend of malaria. We see the malaria cases are more and more every year since the beginning of the 2019 with the COVID-19 coming. Because the people are cannot do regular malaria projects because of the COVID, cannot cross the border, cannot do regular project activities. Combining with the 2021 coup, more people from, especially I guess there's no concrete data, but the assumption is more young people from the urban area came to the border area, because once we know that the malaria is for the newcomer, it's like a newcomer, everybody might get the malaria infected in the area. So newcomer, they don't have immunity to the malaria. So once they come to the border area, because they never get contact with malaria before, it's a kind of serious issue in the border area. So we start to see malaria cases going up and up since 2019 until now.
Okay, thank you. We got a question up there.
Hello, Vanessa Johansson, Local Insight Service. Thank you so much for this fascinating research and for your presentations. I had a question about the reproductive health issue. You mentioned that 58% of women who no longer plan to not have any more children do not have access to reproductive services or to contraception. And that's also, it rings true for us as well in our field, in my organisation's field work. We're hearing about a lot of unplanned for babies being born, particularly in border areas. And I was just wondering I guess two things. How does that compare to the past? I don't think you shared data of what that statistic looked like in the previous sort of pre-coup period. So I'm just interested in sort of how that looks compared to previously in terms of access to contraception, and then I guess what more? I mean, it's the impossible question, I know,
Yes,
but what more can be done to address it? Thank you.
Thank you, Vanessa.
Maternal and child health is one of the priority area for intervention. But actually for access to family planning is stay low, as you may see here. So we have enhancing our capacity for like standardized protocol guideline for antenatal care and access to life-saving emergency service like for cesarean section. And we have found that many women require emergency obstetric, like cesarean section. Also, they cross the border into Thailand to access like cesarean section or emergency obstetric care. And through the network, we also offer long-acting family planning because people are displaced multiple times. So more and more women now utilize a long-acting family planning method. And like even at Medical Clinic last year, every year we have around 200 women come for the long-acting, but gradually this data is increasing. So women awareness and acceptance for family planning and is also increasing. But generally we can say that resources constraint and the multi-movement also restrict their access to the family planning. And just one question I want to highlight about malaria, because in 2005 report, it is revealed that almost 12% of the population infected with malaria during the survey period. And this was through the collective action like Malaria Elimination Task Force. In 2012 data, it showed that almost 80% of the malaria prevalence reduced in the survey area. But after the coup, this malaria is become alarming. Like at Medical Clinic, before that we only have 10 to 12 cases per month, like Vivax. Now we see almost 300 cases per year, no? 10 cases per year to 300 cases per year. So since that time, the Thailand also looking more at like proactive action for the disease surveillance, especially when the vaccination also interrupted or supply chain interrupted. Children, also, many community also start reporting other emerging diseases like polio or diphtheria. So many children also from Myanmar, they also come to Thailand, access for the treatment. So among those are like confirmed diphtheria case. So the Thailand government and CDC, US CDC and Thai CDC, they are looking at to do more disease surveillance and enhancing the capacity of the local ethnic people. And especially they focus now on the polio and malaria and cholera case. But there are still like dengue fever or measles. So, but we do not have enough resources for testing because to identify or case identification, the case or detection and the intervention, we need more comprehensive approach. Disease surveillance is the entry study, see the more proactive action, but at the same time more need to scaling up all the action and more coordinated way across the border, not only in Thailand also, because most this problem is coming through the disrupted of the disease surveillance system. The whole country also, we do not have disease surveillance system is already interrupted, and there is also reported case like polio or measles in the central Burma, but we do not have clear picture of what is happening with the disease surveillance and communicable disease control measure. Yeah.
Thank you, Cynthia. We've got another question there. Do you want to tell us your name, ask your question? Thank you.
Thank you very much. This is Gopi from Health Equity Initiative. So first of all, thank you everyone who supported this survey. This is very useful information for us. And well, it is very sad to see the downward trend of our country, all the results. But when I review the antenatal care coverage, the maternal health coverage, I saw the upward trend from 60% to 90% of the antenatal care coverage. So I have two questions. One is any comments or message you would like to give to the audience who analyze data, for example, any addition or methodology or the coverage differences between 2013, 2019, and 2024, because we all assume that this is very challenging environment, 2024, but the antenatal care coverage has been increased. So this is my first question. The second question is, while the antenatal care coverage, we would say maternal health care, access to maternal health care has been increased, but the infant mortality rate or NFI mortality rate has been increased, a double, triple. So any comments about those, the maternal health care versus a child health care, any message, any comments you would like to give to the audience who analyze this data? Thank you very much.
Did you get that, Sornay?
Yeah.
The first one on
Thank you.
differences of what you found in this latest survey and 2013 or 2019.
Here, I would like to say a little bit about the indicators. I already explained in the previous slides that this data collection, this surveys is out of the government control area. We call it a national data system. It seems there is not changing very much from in the ethnic administration areas since the beginning of 2024, 2004, 2008, step by step now we are in the fifth times already. Especially in the ethnic administration area, ethnic conflict affected areas, the figures are not changing very much. So of course we cannot compare to the national data system because the different areas, different scenario. What we can see is a national data system. They can only get a data from an urban area, mostly out of control area. They don't have an answer. They don't have a data. So I think we're just showing that nationally what is the data we have it. And then in ethnic, because of course we don't have a comparison among each year where we do survey, but we look at looking these numbers now. The data is not changing very much, but of course we cannot compare the national. The national data is getting better within 10 years. Within I can say exactly from 2012 to up to before the coup data. But I think in that scenario, in the political shifting, in the ethnic administration area, still ongoing like this. Many things we have to think about, the service availability, the support, the train, birth attendants, even like we, of course, we appreciate that donors give support, long-term support already, but why this data still like this in that area? Because unstable area, it's conflict-affected areas. You can see everywhere in the world, so that's why I cannot give you a concrete answer, but different scenario. Thank you.
So just I would like to add a little bit more about the antenatal coverage and service delivery. Because since the coup in Myanmar, our healthcare service delivery model have to adapt based on the local needs. So before that, we have village tract health center that can access to like 2,000 population. But because of the geographic constraint and not enough number of health workers can reach out to the community, so sometimes people come to antenatal care visit, especially for first visit or follow up. The recommended like 4 visit is not achieved. But during the conflicts, many people moving, and then health infrastructure can no longer provide service in the facility level only. We have more community outreach program. We have more also, we train more health workers over the past 2 years. So there are more maternal child care service provider reach to this population. And this also one of our response action to reach more population. And we also have many displaced health professionals like doctor, nurses. So we have a lot of mobile health network, expanding the mobile health network so people can access to antenatal care. But actually, the service we provided is like meeting and examination, counseling, and detection. But they are still challenging to receive all the resources, like even we see women require family planning, do not have enough family planning supply, or we do not have enough malaria test kit to test for pregnant women. So we can reach more people, but resources, under-resources. So that means women will not receive quality services or enough care. And for the under 5 mortality, usually in this conflict area, or in the 2005 report, it showed that the common cause, like 75% of children under 5 deaths are due to malaria, pneumonia, diarrhea. So diarrhea, because during the displacement, they do not have enough water sanitation facility, and no vaccination interrupted, so pneumonia is also a problem. And then again, like because of displacement, children undernourished or malnutrition. So these malaria, pneumonia, diarrhea, and this is the impact of the displacement. Or so these are the clear picture we can show that even access point is increasing, but under resources, and also restriction for the humanitarian assistance is still a crucial part to continue intervene these problems.
We've got Dr. Wynn there with a question. I was just wondering, the second part of your question was about infant mortality. Is that right? Infant mortality and maternal health care.
Yeah. Already answered.
Yeah, you've done that. Okay, I'm sorry. Forgive me. Dr. Wynn, what would you like?
Okay. Actually, I'm not for the questions. I just want to add, when you ask the first part of your questions, I understood you asked about the child malnutrition. You was asking about that. That is the one I want to add on. And then second part is I want to support our Sony to answer regarding with the child. Actually, I'm a Burmese origin, but I was in exile since 1988, and I was working in South Africa for 30 years in Ministry of Health. Now I am helping as a technical consultant in Meadow Clinic. The first thing what you ask is, I think I should highlight to all the audience about that, as I am a child health practitioner. When we talk about malnutrition, in terms of our child health practitioners, according to the WHO, is if the malnutrition is more than 5% to 9%, it is a poor condition. If it is more than 100, it is a serious public concern. So when our colleagues Sonny to present, you might notice in some area is MUM. MUM is moderate acute malnutrition is 16.3. That is, we really worry about that, because if it is more than 10%, it is a public concern regarding to the WHO. In some area, SAM and MUM is around 8%, which is also its concern about that. So when we talk about this, I want to a little bit explain about the dangerous of the thing, because this under 5 malnutrition consequences is many things will come that end up with the risk, with immediate risk, long-term risk, and social impact. You name it, everything is. So, child is our future. Child is our future nation. So, if we cannot change it, that will be long-term effect for our children as well as for our nation. So, this is, we must change it as much as possible. At this moment, I understand it is also beyond our limit. So we have to do that for this infant mortality and then the under 5 mortality. That's the one thing. And other thing is one of the colleagues asked about the IMR, infant mortality. That is in here is 62 is mentioned. Actually, it is double of the national figure, and then under 5 is 85 per 1,000 live birth, which is also our nation figure is the last one is 39. So you can compare it. When we talk about that, you might aware some people. We have a previous the Eastern Burma border survey last couple of years and years. And there, when I remember, what they mentioned is national figure is not working for us, for ethnic group. It is 3 or 4 times higher than the national figure. So it means when we talk about national, we should multiply by 3 or 2. So it is a very much serious concern. We have to do that within our capacity. That is, I want to highlight.
Okay.
Thank you.
Thank you. Actually, that's no surprise. That's the sort of thing we've heard before. The earlier reports were saying that, I think back in the 2000s, the figures coming out of ethnic areas were worse than some of the worst affected conflict areas in Africa. We've got another question here. So, thank you.
Hi, this is Miriam Lang from the UN Human Rights Office, OHCHR. I had a couple of questions, actually following up on the under 5 mortality. I was curious because on your slide you presented the numbers comparing it to other conflict-affected areas outside Myanmar, but I was wondering how it compared to the previous survey. So exactly to address that point, to say this is a very particular group of people, and probably even the average for Myanmar doesn't really reflect something comparable. So I was wondering, had it doubled? I mean, because that would be quite telling as well. So I was wondering if you had that data handy. Another question that I had was actually to ask Soepu about sort of the main challenges for the governance structures, like, for example, the Karen Health Department. Yeah. What do you see as currently the greatest challenges given the context you're in, and what have been your priorities? Dr. Cynthia highlighted the expansion of community-based health workers. Is that sort of the way you've been approaching the challenges of the last few years, or are there other priorities? I'd be curious to hear a bit more about that. And then third question, on mental health. I had the pleasure to speak to Dr. Cynthia about a year and a half ago about this. We included some information about the mental health crisis in Myanmar in our report last September. And so I wanted to ask you how you've seen the situation evolve, and what are some of the sort of immediate steps that could be taken to address that, short of ending the conflict. Obviously, I know that that would be the best solution to the mental health crisis, but what are some of the greatest needs, and how would those be best filled? Thank you.
Thank you for your question.
So, thank you very much. Very good questions. So I would like to respond to the first questions about the comparison of these mortality data. This time we use compare the Myanmar national average and some other conflict-affected countries like Syria and Ukraine. Of course, our data mortality rates comparison is not consistent. Previous report we used other conflict-affected countries like Africa countries like how do you call it? I forgot the name, like a very low setting area similar to our setting. We use that Africa countries, Congo, sorry, we use Congo and some other 1 or 2 countries. But this time it's kind of the kind of political notice, I think. Is like Syria and Ukraine is like, you know, people understand, people know about this conflict and being, I mean, so and that like a Myanmar national average. So I think we can more or less compare, because the reason why we can compare is like 10 years ago, before the coup, like the health system in Burma is getting better. Okay, say but getting better. We can kind of, and also 10 years since 2012 up until to I think before the coup, before COVID-19 pandemic, I think in Burma like the year I forgot the name, but within like the time frame is like 10 years. We have a chance to have a talk. I mean, the ethnic health authorities have a meeting with the government's health authorities. Like at that time, we also talk about the health convergence 2 system. The one system is government implemented one system, one health system. Another system is the ethnic health departments implement the system. So we have a chance to have a meeting to talk about how to bridge, how to cover these 2 health systems for the good of the better Burma, where we can image like federal democratic countries or Burma or something like that. But no, at that time, you know, the government also, the health system is getting better, the health services getting better, more access, more connection to the ethnic health department. So more or less we can rely on some data. So that's why this time we also kind of making a comparison for some like mortality rate. Another issue is, I think, the local governance, like, right? You're talking about the KDHW local governance level. Okay, go ahead to respond.
Thank you very much. Just want to add a few information regarding to the comparison, the different report for the infant mortality rate. We're sorry that we are not able to answer concrete answer from here, but you can go directly to the HISWG.org or EDHS.org. So the report has been public there, so you can easily compare the different information from the different report and different years. Thank you very much. For the local governance, KDHW itself, we have been trying many years, but since 2023, we have been strongly collaborated with our partners, including the local as well as the development partners. But as we all know, in the the end of 2024, the impact of the USAID funding is it's quite became the challenges for us to continue to do for the local governance. However, we are now turning to another point that we have another partners who want to strengthen the ethnic health system strengthening. So this is including with the KDHW. So we are now in the process of the forming the what we call the quarterly health sector coordination platform, which is trying to bring a different health partners who are working across current control areas, so we can share the data, making the collective decisions, something like that. Moreover, we are also now establishing the the Quarterly Institute of Medical Science, which is we're trying to strengthen the HRA system in terms of the public health in the futures, in order to have advanced healthcare, from the public health. Yes, thank you very much.
Okay, thank you. We've got a question there, the man in blue.
Yatu Razak. There's no affiliation with any organization.
Sorry, can I get your name and where you're from? Sorry.
Myat Tu Razak.
Okay.
I have no affiliation with any organization.
Okay.
And so thank you very much, everyone, for working very hard to get the survey. As you mentioned, there's a lot of limitations. At the same time, you have covered so much, so this information will be helpful. So my question is, I have worked with Meta for many years, and so I'm a physician epidemiologist from Burma, but I've been outside for more than 35 years. And so what we have worked before, and looking through this is like you need support. And you have been doing great and working under very difficult circumstances and saving many people's lives and providing healthcare. And so my question is, as a former funder, and how are you working with the funding institutions? Because you have a recommendation very clearly about several partners that you can work with, diplomatic communities, international organizations, and investors, and many others. And so my question is, if the funding institution or the support is not the priority that you have, how do you address it with that funding institution? Because sometimes funding institutions have their own priority in coming over, but your priorities may be different because right now, after the coup, even getting more challenging. And so how are you addressing it, and what kind of leverage do you have in talking with the funding agencies or organizations like UN or any private partners? And so if you need some other leverages, how can we, as an independent, working in different institutions before, and we have a lot of networks, how can we really address these people who are so dedicated? I'm not talking about funders, I'm talking about funders. They're dedicated, they're really trying to work hard for you, but sometimes they have their own organizational priorities, and so they may not be able to overcome it. So how can we assist as independent and establish people with networks? So that's one thing I would like to hear, because you may not be able to talk too much directly with the funder, so I'm here to hear it, to listen to it, and if you cannot talk now,
I
we'll
think
be happy
that's
to talk.
part of the reason they're here, actually, obviously, but please.
I'm not so sure whether they can talk all the time, so that's why.
Thank you very much, Natura, that I think you are our senior. I think also we still have your commitments, your support in terms of everything. And then I can really see something about like our networking. We build up our networking like in terms of the health information. We have a health information system working group. In terms of the system building, we build up our networking like our ethnic health system strengthening group. In terms of health and politics related issue, we build up the HISWG Health Convergence Core Group. And through that networking, we are considering like a kind of the collective effort, collective leadership, because only me alone, only Dr. Cynthia alone, only Apple alone, only Dr. Dewi alone cannot do everything. So we all come together as a network. We try to bring each other. Try to bring each other. We foresee, of course, that we are not the legitimate. There's a very big word. Legitimate government, not even like a legitimate governance yet. But anyhow, I think the ethnic administration area is kind of the de facto governance already. So there is, it might be difficult, but I think in terms of to continue to do the health support, health service delivery, I think everybody here are responsible to consider, to fulfill, to support us. That's why we are here. We are showing our data, we are showing the needs. We are showing, we are calling for the needs. So I think we all are responsible to contribute what we can do it, because we are building our country. We are building even like a state rebuild. We rebuild state level, not like a bigger the federal union yet, but under the federal union, there will be many different sets of federal units, federal states. Now we focus on in the ethnic administration area. Everybody want to have want to be in part of the federal union. They are a part of the federal union. They are a federal state or otherwise federal unit. They are trying their best in terms of the ERO. They are trying their best how to lay down their own state constitution after the state health state health policy, something like that. There will be a process, but of course, in terms of the support, because of the global crisis, we know it, but I think more or less we can carry on. But of course, we need our input or support for all of you. Thank you.
Thank you. We've got another question.
Hi, thank you. My name is Loon Piper with OHCHR. My question is regarding SGBV incidents and needing help and treatment for those type of incidents. Are you able to collect data or survey regarding those incidents, and with the whether it be emergency health treatment or contraception, and providing all kinds of services? Have you been able to provide those things, and if so, are there any other additional challenges in treating or encountering those SGBV incident cases? Moreover, after the 2021, has there been an increase, and how are the difficulties in dealing with that? Thank you.
Thank you very much. Honestly, collecting the GBV data it's a very limited because it is a kind of the cultural norm or whatever. So we have a very limited data for your SGBV cases. In terms of the case management or reporting system, we current health department and other social CBO and CSO, including with the current women organization, working very closely for the case management, as well as the justice or law enforcement, so or the safety or safe house or whatever for those who suffer from the SGB cases. And, to summarize, we have a very limited cases from the GBV cases. For treatment, I think I will refer to the either Dr. Taewin or Dr. Cynthia. Thank you very much.
Okay, you can follow up for further answers after this ends. We've got another gentleman there.
Yes, my name is Joe from the Burma Health Work Guardians, Deputy Director. Yes, I would like to ask no question, but I would like to add that one question is left. That is the mental health question. So in Burma, the COVID, since COVID-19 and beyond the Burma military coup, most people suffer from the social mental problem, not only in the urban area, but also in the ethnic areas, including the health worker, also the civilian, and also villagers. So that's why now we need that. So that's why now we conduct how to provide them mental health issue or something like that. Also how to provide the psychosocial support, something like that. Now, so one question is that the lady asked, what do we need? Now we need more medicine and more supporting for those mental health issues.
More medicine.
More medicine and more mental health workshop and training.
Okay. Yeah. Yes. I think I've needed that for years, frankly. But forgive me. We've got one more lady there.
Hi, thank you for the sessions and really interesting. I am Ying Kamsin from the International Food Policy Research Institute. Our organization also working on the national household survey in Myanmar, but it's through the phone call only. So we have very limited time to collect all of the data, but we did Myanmar National Household Welfare Survey starting from 2020. And it's already 9 rounds here. We are currently studying the 9th round. And we have about 12,000 households for the whole Burma. And we have fairways and poverty information, but not very deeply about the health access and something like that. And we cannot cover you have done in a conflict area and in the border area, especially in the Karen and Chin and Kachin state. So here my question is, if it is possible, would you like to share the data with us and maybe we can collect for the data analysis? And my second question is how you manage on the enumerator safety for the data collection. Yeah, my question might be out of other interest. Thank you.
Thank you for explaining your work, your effort to collect the national level data. In terms of collaborating effort among us, I think we are slightly different, but I think we need to get to know more each other first. In terms of data sharing, so we need to, based on our data sharing policy, you can have a connection with the HISWG website, and we laid out data sharing policy already there. So I think we have to communicate to each other and see what we work out. Thank you.
Okay. Just one last question. This was mentioned to me prior to the start of this event, that the SAC or the whatever the military government is calling itself now, have stopped giving antiretroviral drugs to people with HIV. Are you seeing a flow on of people to the border? Are you seeing more people who no longer have drugs to treat HIV?
So since the coup in Myanmar, we have seen people crossing the border from Myanmar to continue access ERT. So before ceasefire 2012, our patients who are living in Thailand, they access ERT from Thai National Program under Global Fund support. But in 2012, Global Fund pulled out from Thailand and support through Myanmar National Program. So since that time, we transfer patients to Myauri Hospital. So people can access ERT in Myauri Hospital. And after 4 years of almost 200 people being transferred to access ERT from Myanmar National Program under Myauri Hospital. But after coup, people who can no longer access ERT from inside many other regions, not only in the Myauri area. So they come to Thailand. So currently, gradually, our number of patients who access ERT in Thailand increasing. So in last month, we also have meeting with the Mass Health General Hospital. So in Thailand now, they also receive a global fund for 1,000 population, like Burmese migrant population. So among 1,600 is for the Thai province. So like they have to share some of those who are living in the refugee camp, some of those under medical clinic, and some of those directly access ERT from other NGO, refer from other NGO. So they also have some limited number of ERT, only 600 cases. But every year we see that the HIV, at least 100 new cases.
100 new cases a year.
Identified. So we have to expand our program, both refer to Thai government hospital, or some of those we can receive in-kind donation for medicine. So now ART is treated in 3 areas, one in Mass Health General Hospital, one in medical clinic, and one in Myauri Hospital. But there is no connection between the Myanmar and Thailand program.
Okay.
So currently, since ART program stopped in the NGO program, no? So like some of those who access ART through IOM or World Vision, or they refer back to us again because people cannot access inside Myanmar.
Okay.
Because they are not registered in Myauri, or they are not resident in Myauri, so they can no longer access.
Okay.
So they
Okay.
just, I heard that they were going to refer back to medical clinic.
Okay.
So that means we will see more people who require ERT.
Okay. Ladies and gentlemen, any more questions? Dr. Vitt, I see you. Any remarks you want to make about, briefly, in terms of impacts on ethnic groups? This is Dr. Vitt from Chiang Mai. We've had him before in these panels.
I was trying not to be able to speak at this event, but hi everyone, my name is Vitt. I'm an internist and epidemiologist, and I've worked with our partners on previous reports for many, many years. I think, the takeaway message for me, looking at all of these, I was much less involved in this one, is how little things have changed and how much backsliding, in fact, there has been. Because if you look at the snapshot as a whole, I mean, the health indicators pretty much are unchanged, if not probably worse. But then the other thing that really strikes me is like how much trauma there is out there. How many households have seen violence? How many people have had to flee? And how many people are still trying to flee Burma? And when you couple that with what we already know in terms of health has unfolded since the coup just along the Thai border, for the first time we've seen deaths from diphtheria the last year. We've seen
Deaths from what? Sorry?
diphtheria.
Okay,
You know,
diphtheria.
we've seen malaria cases go through the roof. We saw our first cases of cholera in decades here. That hasn't happened for a long time. You know, put it all together, and this is a health catastrophe for the region. And you know, my take-home point for outsiders looking at all of this is just, you know, in the midst of all of this, we have aid cuts, we have funding cuts, we have decreased support. These are the groups that really we have to be stepping up and supporting, because all these health issues we're seeing already are not confined to Burma. They're really the unspoken casualties of Burma's coup and civil war. And they're creating a health security crisis for all of us. I can bet you dollars to donuts that there are far more people in Thailand dying and getting sick and getting disabled from consequences of Burma's coup than direct conflict. And I wish we would see kind of our wallets step up to address that.
Thank you.
Thank you very much.
Would you, our esteemed panelists, if you'd like to, you've had a lot to say. If there's nothing further to say from our panel, ladies and gentlemen, that's the end of it. And Cynthia, you're okay? No, nothing more?
Well, I would like to thank all of you that coming together. I think we are here. We show what we find. We also asking for the help needs, and also I also talk about the people alone, individual people cannot proceed with this process. So I think we need all of your help in terms of a technical issue and donor support, financial support, technical support. I think we all, if we work together, I think we can overcome the very big difficulties. I think we have been doing these very big jobs already. I think we are kind of ourselves is also resilient. I think already. If I talk about resilience, I think our Burmese people are really resilient to the situation, because since independence of the country, not really true independent, but you know the people in Burma are facing all difficulties all over the country. But you know, especially the most like the rural areas of the country, especially the ethnic areas. It's been like more than for the current more than 70 years already. The people are still there. Why they are there? Because they born there, they stay there, and they grow up there. They adopt a situation. They need a system that suits, fit for them. But I think they are strong enough. They are resilient enough. Even ourselves also, we are resilient. But we worry a little bit because of the global change, the global crisis. But I think if we all together, if we help each other, I think we can overcome their problems. Thank you.
Ladies and gentlemen, thank you very much. Thank you to our panel, and thank you, guests, for coming. Please join us for, if you want to come and ask questions here, or we'll see you for a coffee. There's a little bit of food there as well. Thank you.